Bismillahirrahmanirrahim and Assalamu alaikum. Dear students, today we are going to discuss very important topic in dermatology as well as in the field of medicine, which is cutaneous tuberculosis. And as we all know that tuberculosis is a common infectious disease in Pakistan, especially in developing countries, but it has also got manifestations on skin which being a medical student, you should know about the different forms, different types of cutaneous tuberculosis, its presentation, so that you would be able to suspect at least these cutaneous manifestations of tuberculosis, because we commonly know and we are aware of the pulmonary tuberculosis, but it has got this manifestation on skin also. So basically we are going to discuss broadly the causative organisms, history of Mycobacterium tuberculosis, the morphology, and especially the classification of cutaneous tuberculosis, and in the end we'll discuss briefly about the treatment and management of cutaneous tuberculosis. The causative organism is Mycobacterium tuberculosis, and it is basically broadly divided, so it can be Mycobacterium bovis or Mycobacterium tuberculosis, but humans are mostly affected obviously by Mycobacterium tuberculosis. Mycobacterium tuberculosis, the causative organism is the gram-positive and strongly acid-fast in character, which helps in the staining of and diagnosis of Mycobacterium tuberculosis on histopathology, and it is aerobic, non-spore forming, non-motile and facultative intracellular curved rods. So this is the characteristic of this organism, and the cell wall is rich in lipids and mycolic acid, which is a reason for long-term treatment or sometimes the resistance to the conventional anti-tuberculous drugs. And by character it divides every 15 to 20 hours. It's a long time, so it stays for a longer period of time and resistant to treatment, and it is usually identified on staining, being character in, because this is acid fast, so organisms are identified by their red color on acid fast staining. So students, this is very important slide which gives you overall idea, so must look at this slide carefully, because this is just classifying cutaneous tuberculosis in a table form. So if we just go by the route of infection, so number one is the inoculation tuberculosis, which is an exogenous source. So by any trauma or external injury, the causative organism is introduced into the skin and then causes its manifestation or different morphological types. So clinical types would be tuberculous chancre, tuberculosis verrucosa cutis, and lupus vulgaris, which is rare if we are talking about the exogenous type or inoculation type. So these are the clinical types of inoculation tuberculosis. In case of tuberculous chancre, it is non-specific histology, but in case of tuberculosis verrucosa cutis or lupus vulgaris, this histopathology or histology is typically specific, which we'll discuss in later part of our talk. Coming on to the secondary tuberculosis, which is an endogenous source. So if patient is suffering from pulmonary tuberculosis, patient can have its manifestations on skin. So it can be contiguous spread, or it is auto inoculation, because as far as like in the lip area, if it is bitten by teeth, or patient is actively tuberculous patient, so he or she can have the clinical type like scrophloderma or orofacial tuberculosis, which is a localized type. So it is manifested locally on the specific area, or it can spread from the lymph nodes to the skin in a form of sinus formation, which you clinically see in scrophloderma, which is a secondary type of tuberculosis. The main source or main area affected would be near the sinus formation, which you can see on the skin, and this bacteria, or it is causing its manifestation on the adjacent skin in the form of sinus. Then is the hematogenous tuberculosis through blood, which is spread to different parts of the body and have its manifestation. And this clinical types include acute miliary tuberculosis, commonly lupus vulgaris in this type, which we earlier said it is occasionally inoculation form also, but mostly it is by hematogenous spread. Then is the tuberculous gamma. So these are the types which are spread from the primary source to the cutaneous sites through blood, or it has got hematogenous spread. And the last is the eruptive tuberculosis, which is a form of a sensitivity reaction, and to distant sites. These are the clinical variants of cutaneous tuberculosis, where there is nearby no actual primary infective source, but by the hypersensitivity reaction or type 4 reaction, the antibodies react to antigens and cause delayed reactions and manifestation on skin in different clinical forms. So it includes lichen scroflosorum, second is papular or papulonecrotic tuberculate, and third is erythema induratum, which is also called erythema induratum of Bazin. So if we just typically see a pathology of the biopsied lesion for the diagnosis purpose, the typical character is a tubercle, which is a avascular granuloma. It is composed of central zone containing giant cells with or without caseation, which is a typical character. So caseating granulomas are one of the characteristic lesion in histopathology if we are diagnosing a cutaneous tuberculosis and looking at the histopathology, and it is surrounded by lymphocytes and fibroblasts, as you can see in the picture. So here it is clearly shown, a central caseating granuloma with peripheral lymphocytes and fibroblasts. Here I am trying to show some of the typical lesions of lupus vulgaris, which we earlier mentioned that it is mostly caused by hematogenous spread from the primary source like pulmonary tuberculosis. So in these lesions, the important thing which you should notice that there is central atrophy of skin, this is scar-like tissue, and it is surrounded by thick border, which is hyperkeratotic border. So any lesion of long duration or a chronic lesion with central atrophy, we should suspect lupus vulgaris, and we should investigate accordingly. So as we just showed you some of the picture of lupus vulgaris, it is most commonly in 90% of the cases it involves head and neck region, but in Pakistan we usually see in the lower half of the body, especially on legs, maybe arms. Patient gives history of painless reddish brown soft nodules. So painless is an important character. Any patient complaining of a chronic lesion which is not very painful or almost painless and slowly growing with characteristic central atrophy, and gradually, initially it is like in the form of soft nodules which enlarge. The central area becomes atrophic and the surrounding border is well demarcated and thickened, hyperkeratotic. It's form of a plaque. So central scarring or peripheral with peripheral hyperkeratosis, hyperkeratotic lesion of chronic duration. It is one of the typical characters of lupus vulgaris, which is a type of cutaneous tuberculosis. Here I've just tried to show briefly if we suspect any form of cutaneous tuberculosis, especially lupus vulgaris. Just a simple test, it might be helpful in some of the cases. So you just press hard against the lesion, and when it is avascular, you see a nodule, as you can appreciate in this picture. So it appears as a yellowish brown color spots, which are in medical terms it is called apple jelly nodules. So this is one of the signs of cutaneous tuberculosis. So here, as we had discussed, scleroderma is a type of cutaneous tuberculosis where the actual source of infection is near the lesion which you are looking at. And here is the typical picture and example of that. This is called scleroderma. So remember this because you come across these lesions with multiple sinuses of chronic duration. So I've just tried to show in this picture the typical sites and typical form of scleroderma, which is a type of cutaneous tuberculosis, and this is a secondary type of cutaneous tuberculosis. So here is the other site and clinical feature of scleroderma. As we said, it is from the underlying involvement with tuberculosis, and then it spreads out to the skin in the form of sinuses. The focus may be lymph nodes, lymph glands, then bone, joints, lacrimal gland or lacrimal duct. It is mostly asymptomatic, well demarcated, freely movable bluish red nodule if we examine them on physical examination, and then these nodules breaks down to form the sinuses, as you can see, discharging sinuses. And we had earlier seen in the previous slide also that there were multiple discharging sinuses, because there are they break down to form these undermined ulceration with underlying channels inside the skin. And on histopathology, these are having the granulomas and granulating tissue at the base of these lesions. So this is another type of inoculation tuberculosis which we had earlier discussed in our classification. and inoculation means that the organism is inserted or it is introduced into the skin by some external or physical trauma. So it's also simply called warty tuberculosis because morphologically it looks like a viral wart, but it is larger in size, and we'll discuss the characteristics of this warty tuberculosis. But other names given to it, especially which is commonly used, is tuberculosis verrucosa cutis, and some of says anatomist warts, because they usually get these sort of warts on hands. So these are the few of the synonyms. Clinical features, as you have seen in the picture also. It is basically mostly found on the external parts and on the limbs, because it is an inoculation type, and characteristically lymphadenopathy in this surrounding area it is not seen. It is very much localized, and there is hardly any formation of sinuses like superfluoderma, or any prominent atrophy like lupus vulgaris, which we had seen in the earlier pictures and earlier description. Now clearly we can see in the picture small asymptomatic red to brown warty like papule, which then changes into a plaque. So in the picture which you are clearly seeing a plaque on the hand near the thumb, and it extends to form a verrucous plaque. Fissuring or discharging pus can be occasionally seen, but it's not a common feature, and if it recovers or regresses after 6 months to 1 year time approximately, it leaves a white atrophic scar. Now this is also another type of inoculation tuberculosis. The important thing you need to remember that is mostly it occurs in the children, or in early adulthood, and incubation period is approximately 2 to 4 weeks. After inoculation, a brownish papule or nodule is formed, which changes into an ulcer, which is a non-healing ulcer, which is an important point to be remembered, not responding to conventional antibiotics, or it later on forms a crust. So as you can see in the picture also, in front of the thigh or on the foot, it's an enlarging ulcer with a crust, and it is recurring. And if you examine, you especially found unilateral inguinal lymphadenopathy or lymphadenopathy in the concerned area if the ulcer is present in the vicinity. So this is another type of tuberculosis, which is called acute miliary tuberculosis. It also affects young children, but the important feature is that it usually occurs in immunocompromised patients, in children of lymphoma or leukemia or concurrent HIV infection. Here we see minute bluish papules, vesicles, or hemorrhagic lesions, which are not usually a feature of tuberculosis. So it is difficult to suspect this type of tuberculosis clinically until unless we confirm our diagnosis with PCR or other tests, which we'll discuss later in the part of the lecture. So important feature which you can look for is enlarged liver in 40% of the cases, enlarged spleen, inflammation of pancreas, or multi-organ dysfunction. Especially it involves adrenal glands, and dysfunction of adrenal glands also shows its signs and symptoms, especially in the form of hyperpigmentation or these imbalances or by negative feedback. Then there is other inoculation type of tuberculosis which is called orofacial tuberculosis, and by the name it is quite obvious that it mostly occurs around the oral cavity, around the lips, mostly in males, around the mucosa. So similarly, reddish nodules they form, and after a few weeks or months time they break down to form ulcers, and if you examine the ulcer you will see an innervated base with undermined edges and bluish margins, and the base is hemorrhagic and granulomatous. So it's also a type of inoculation tuberculosis. Metastatic tuberculosis abscess or tuberculosis gamma is a very late feature of patients suffering from tuberculosis. Mostly occurs in immunocompromised patients having leukemia or lymphomas, and mostly occurs in the distal part of the body, on the limbs. First the subcutaneous nodule or abscess is formed, and then it breaks down to form an ulcer, as you can see in the picture. And it is this type is mostly come in the differential diagnosis of actinomycosis, because similar discharging sinuses are formed. Sometimes we also confuse with other type of tuberculosis, as we discussed earlier, sucrophroderma. Similar nodules and sinuses are formed, but here commonly we should remember that on X-rays bony structure or the bones, long bones, periosteum is also involved with tuberculosis gamma. But if we go for biopsy, typically we see the caseation necrosis, so that would help in the diagnosis of cutaneous tuberculosis and tuberculosis gamma. Now we come to another type of cutaneous tuberculosis presentation. It is a rare variety, and it's difficult to diagnose, but you people must have idea about this type of cutaneous tuberculosis, because it is due to the hypersensitivity reaction, and it's not a primary inoculation or the primary focus of Mycobacterium tuberculosis. So basically it was discovered by Derrier in 1896, and he recognized it, and you must concentrate on few of the criteria which we fulfill for confirmation of diagnosis. There are different varieties of tuberculosis, but the skin lesions on biopsy, they must show tuberculoid histopathology, and most importantly, Mycobacterium tuberculosis or the bacteria itself, it is not recognized in the lesion by acid-fast staining, and the tuberculin test must be strongly positive, because as I mentioned, it is a hypersensitivity reaction, so it is an immune response by the patient, and the treatment of underlying tuberculous focus clears these lesions, so that is also a therapeutic option, and further confirm the diagnosis of tuberculosis. Now this is a variety of tuberculosis which is named as lichen sclerophorum. It is the most common pattern of tuberculosis, especially it's presented in children. Now students, you need to focus, it presents as grouped micropapular lesions which are isomorphic, yani they are similar to each other, and looks at mostly at the site of abdomen, and there are multiple, you can say, patches of these group lesions. So they are micropapular group lesion, and there are multiple spread all over the trunk in different groups. And if you examine the patient, the cervical, mediastinal or hilar lymph nodes are found to be enlarged. So this is one of the variety of tuberculosis. So the papules are skin color, and they are grouped in presentation. So here is the other slide of lichen superficium. I think you can better recognize lesion in this slide. And as I mentioned, the size is approximately 0.5 to 3 millimeter, closely grouped. They present around follicular or perifollicular papules with a very fine scale. So you need to just keep this presentation or picture in mind to at least suspect this type of tuberculosis, and try to investigate the primary focus of tuberculosis. And if we go for the therapy, the lesions usually clear within 4 to 8 weeks without scarring. So in histology, if we go for the biopsy, superficial dermal granulomas, which is the hallmark of tuberculosis. These granulomas are seen usually around the hair follicles or the sweat glands. Another type of tuberculosis is papillonecrotic tuberculosis, and it is also mostly presented in children. And clinically we see papillonodular lesions which are smaller in size, around 2 to 8 millimeter, and they are widespread, bilaterally symmetrically presented. But usually these lesions are presented or preceded by fever, and constitutional symptoms are severe. So patient gives history of fever, malaise, and finally when they heal, the characteristic of the healing of these lesions is very uniform scarring, which is chickenpox like scarring, in approximately 4 to 6 weeks time, and they are mostly presented on the extensor aspects of the body. Erythema induratum of Bazin. This is also type of tuberculosis, but mainly it affects the subcutaneous fat, causes paniculitis, which is inflammation and involvement of the subcutaneous fat. 4 times it is common in women, and its presentation is the important thing which you need to just remember. It is presented in the form of nodules, but not in front of the shin or legs. It is slightly on the lateral or posterior side of the leg, without much of pain, and very mildly tender. Lesions are chronic nature, not responding to conventional antibiotics, and they are ranging from approximately 5 to 7.5 centimeters in size. So calves are the main area or target where these lesions develop, and you can on examination see some of the discharging nodules. They may ulcerate, but involving deep cutaneous or subcutaneous or deep tissues, and the margins are irregular, and these are undermined with bluish margins. So this is another type of tuberculosis and presentation of cutaneous tuberculosis. Now students, we come to the last section of the lecture regarding this talk on tuberculosis, which is a very important part. Once you have suspected or you have diagnosed case of cutaneous tuberculosis, how to proceed further and how to confirm your diagnosis, and then finally how to treat it. So investigation and treatment is the important area where we should manage the patient. And if we talk about laboratory diagnosis, just look at this slide which would give you overall idea. So it is basically divided into three basic parts. We can directly detect Mycobacterium tuberculosis by different methods, or we can confirm it by culture, and third is the identification of certain proteins or certain nucleic acid sequencing to confirm our diagnosis. As you see on the right side of the slide, just to be very sure and give you overall idea, there is absolute criteria for confirmation of diagnosis and there is relative criteria. So just concentrate regarding the absolute criteria is the culture. Once it's positive, it is considered very specific with high specificity. And second one is PCR or polymerase chain reaction. It's also gives a very strong confirmation of diagnosis. In the relative criteria, history, family history, skin examination, clinical examination, and any test by enzyme-linked immunosorbent assay for antibodies to purified protein derivative of tuberculin reaction, or ELISA against Mycobacterium tuberculosis antigen 6, or with the staining if we see the bacilli in the lesion, and fluorescence staining for Mycobacterium tuberculosis with other stain other than Nielsen stain, which we will discuss just now in the later part, with oramine or other dye like rhodamine. And last but not least, if patient is responding to tuberculosis therapy, that is also one of the relative criteria for diagnosis of cutaneous or cutaneous Mycobacterium tuberculosis. Montos test is still being frequently done in Pakistan, in poor countries where there is problem of affordability. So simply PPT antigen, it is subcutaneously inserted, 0.1 ml of 5 tuberculin unit, and as you will see in another slide, you will see the reaction, and according to the reaction and the size of the reaction in the form of a few vesicle or pustules, you have a set criteria to suspect or to confirm or suspect the diagnosis of tuberculosis, Mycobacterium tuberculosis. As I said, forearm is the usual site, and after injecting 0.1 ml of purified antigen, forearm should be examined within 48 to 72 hours, and reaction comes in the form of an induration, the swelling around the injection site, as you can see in the picture, and it is measured in millimeters, this reaction, and that measurement or assessment of the lesion would help you to suspect Mycobacterium tuberculosis. It depends on the measurement or the size of the reaction, where you confirm the diagnosis of Mycobacterium tuberculosis. As you can see, the positive test is suspected when it is around 10 millimeter of size in reaction, but it is a relative confirmation. It can be false positive, but remember, if it is 15 millimeter of size or the reaction size around the injection site, then it has got more specificity and it is more confirmatory of diagnosis regarding tuberculosis. But this test has low sensitivity and it can be false negative in immunocompromised patients or patients with HIV infection, because they have a poor immune response. So in that case, this test can come negative, or it is not considered confirmatory, so it can give you false negative reaction. The sensitivity is around 58% and the specificity is 62.5%. So we can also directly detect the Mycobacterium bacillus. As we said, it is acid fast interactor, so Z nasal stain is usually used, and as you can see in the slide, the reddish bacilli which are stained acid fast with this stain, they can be detected. And the other stains which are used to detect, which are a bit more expensive, it is the fluorescent dye, auramine dye and rhodamine B. We can also go for the culture, and as I said, in the absolute and relative criteria, culture is the absolute criteria. The only drawback is the longevity of this test results. So it comes positive in 3 to 6 weeks time, and in liquid media it is around 4 to 14 days. But culture is also considered an important confirmatory diagnostic test to confirm the Mycobacterium tuberculosis. Polymerase chain reaction is one of the most important diagnostic tools in the detection of Mycobacterium DNA itself, and it is demonstrated in histopathological tissues or the secretions. And one important thing is that it is giving you results in few days, in 1 to 3 days time, and also helpful in tuberculosis, which are the hypersensitivity reaction to the primary tuberculosis, and tuberculosis present at the distant or different parts of the body. As we have discussed, you can have a detailed look at the lesions and the criteria for tuberculosis. So PCR test is important in confirmation of Mycobacterium tuberculosis. Now this is an important slide as far as this test is being done now in our setup, and this is very important test once patient is not clinically showing signs of tuberculosis, but on cutaneous examination you suspect tuberculosis. Other tests can be false negative or false positive, and obviously there is a concern of mostly patients in our poor setup, where patients can't afford PCR or other confirmatory costly tests. So it is one of the tests which is relatively giving quick results, and it is based on the fact that the T cells are releasing interferon gamma, and if by ELISA we detect those secreting cells, secreting T cells, this is called a T spot test with high sensitivity of approximately 87% and specificity of 86.7%. So it is also called quantiferon TB gold measure test. So this is something which is an important diagnostic tool in the confirmation of latent tuberculosis. So if we briefly discuss treatment, these are the important drugs which are considered first line medicine or treatment for Mycobacterium tuberculosis. It is rifampicin, which is bactericidal, pyrazinamide, isoniazid, streptomycin and ethambutol. The second line drugs are also a therapeutic choice if patient is somewhat having contraindication to any of the first line drugs of Mycobacterium tuberculosis treatment. So second line drugs include levofloxacin, moxifloxacin and nowadays linezolid. So these are considered second line drug as far as the treatment or management of Mycobacterium tuberculosis is concerned. So these are the usual choices which are effective against Mycobacterium tuberculosis. Isoniazid and rifampicin, these are the treatment of choices in the first line of treatment, and isoniazid inhibit the synthesis of mycolic acid, resulting in disruption of bacterial cell wall. But we need to remember that we should give pyridoxine 25 to 50 milligram orally once daily to avoid chances of peripheral neuropathy due to isoniazid. And rifampicin, it inhibits DNA dependent RNA polymerase activity. Isoniazid is given around 5 milligram per kg body weight, and rifampicin is given as 10 to 15 milligram per kg body weight. Third drug to be used in the first 2 months is pyrazinamide and ethambutol. So we start with usually with 4 drugs, but after 2 months of treatment, ethambutol and pyrazinamide are discontinued, and isoniazid and rifampicin are continued for the rest of the time for 6 months, 9 months, or in case of cutaneous tuberculosis or extrapulmonary tuberculosis, it can be given up to 12 months. So briefly, after discussing the treatment of Mycobacterium tuberculosis, we end this talk, and I hope and I thank you all for patiently listening to this important topic, and it's also important in dermatology, where it is sometimes difficult to suspect or diagnose or clinically diagnose case of cutaneous tuberculosis. But I hope and I am sure you must have got some basic idea of this type of tuberculosis, which is involving the skin with different morphological variants. and how to diagnose it, how to approach the diagnosis, and then finally how to treat it. Thank you once again and stay blessed.